I give a clear Google map. Being a laparoscopic surgeon, I always see the MRI films before I start the surgery. It is a pleasure to see the same findings when you are doing laparoscopy. It really improves your clinical skill when you examine the next case. That picture will come to your mind. There are some more things we have to watch when you are doing ultrasound. The uterine musculature, in adenomyosis, there will be small cysts. Some are measurable, some may not be able to measure it. They will just give echogenic foci. If the measuring cysts are there, more in the anterior wall, posterior, lateral, you have to mention anything more than 2 mm, you have to count and you have to document. And most important is, we are seeing lot of adenomyosis and endometriosis in nulliparous women. So as a laparoscopic surgeon, the responsibility is to conserve the uterus. To conserve the uterus, you should have clear thought before you start operating. Where is the disease? What is the extent of the surgery you are going to do? For that, you have to specify whether this adenomyosis is focal adenomyosis or diffuse. How will we classify? Anytime that adenomyoma is surrounded by more than 25% of healthy myometrium, it is a focal adenomyosis. If it is less than that, it is diffuse adenomyosis. Needless to say, there will not be only focal adenomyosis or diffuse. Sometimes it will be a mixed picture. Then you have to mention there is areas of focal adenomyosis in addition to diffuse adenomyosis. And where is the location? And most characteristic feature of the adenomyosis is the junctional zone. Usually the junctional zone is very well defined and measurable. In adenomyosis, either it is ill-defined or it will have breaks. So the myometrial thickness can be divided into 3 layers. The layer which is very innermost is just adjacent to the junctional zone and which is clearly defined. If it is having irregularity as ill-defined, it is a characteristic feature of adenomyosis. The second layer is between the junctional zone and the vascular arcade. The third is between the vascular arcade to the serosa. So when you are doing your ultrasound, you have to mention whether it is involving the lower 1/3, 2/3 or 3/3. If it is involving the serosa, you have to be very careful whether it is going beyond and getting adherent to the pouch of Douglas or to the intestines, which can be elicited by dynamic ultrasound by seeing the sliding sign. If the uterus is moved, with the other hand, which is not having the probe in your hand, you push the uterus, or with the probe, you try to slide and see whether the sliding sign is positive or negative. Thereby, you can assess whether the pouch of Douglas is obliterated or intestines are involved or not involved. It is very essential because as a laparoscopic surgeon, if you have already assessed that the pouch of Douglas is obliterated and the intestines are involved, your counseling and method of treatment, even preparation of the patient before the surgery will be entirely different. So you should have assessment of these cases. One more beautiful sign is the alternate hypo or hyperechoic layers which radiate fan shaped from inside to the outside. These are because of the islands of the collection of the endometriotic tissue in the myometrium. Mention blend sign, like how we will have our windows blends, these alternating fan-shaped shadows is very, very characteristic of adenomyosis. So these are the things we should remember and mention when you are doing your ultrasound. Globular uterus, asymmetry of the uterus, and which wall it is involving, anterior, posterior, right lateral, left lateral, size of the uterus, myometrial depth, to which extent it is involved, cyst, where they are, focal adenomyosis or diffuse adenomyosis or complex of it, then all these fan-shaped shadows, all this consists of a detailed description of the uterus. Lot more is there regarding endometriomas and chocolate cyst and adjacent organ involvement. And there are various other tools have also come. in the MRI also. I think that is a cup of tea for Dr. Lakshmi.
Yes.
So
You
I
already gave a comprehensive view, ma'am.
Thank you so much, madam. Thank you for all the clinical inputs and the role of ultrasound, especially transvaginal ultrasound, 3D, 4D scanning in the evaluation of adenomyosis of the uterus and endometriosis. That is the first step to evaluation of endometriosis, definitely. But MR has its own place, like it will show a lot more details compared to ultrasound. So with that, I'll invite Dr. KL Srujana, our very senior radiologist, and she's an MRI specialist from Vizag, Vijaya Diagnostic Center. Dr. Srujana has done her Diplomate of National Board from NIMS Institute of Medical Sciences, and she's been consultant with Vijaya for the last 13 years, and she has immense interest in gynecological imaging and, of course, abdominal imaging as such. With a small introduction of Dr. Srujana, I'll invite her to present on the MR evaluation of endometriosis and adenomyosis. Over to you.
Thank you, sir, for introducing me. Already, ma'am has given a very comprehensive view regarding ultrasound also. I'll be briefing about those features in MRI.
Can you share your PPT, Srujana?
Yes, ma'am. Yes. Is it visible, sir?
No. We're not able to see you. See the PowerPoint. I think you have to share it. Yeah, now I think it started sharing.
Yes, sir.
No. Yeah, now we are able to see. Yes. Sure. Yeah, that's when we are able to see it.
Yeah,
we are not able to hear it, but yeah, right, yeah.
Now you are able to hear, sir?
Yes.
Today, I'll be discussing about the spectrum of endometriosis and demonstrate its common and uncommon areas of pelvic and extrapelvic disease, and determine the role of imaging in staging of endometriosis and discuss the importance of structured reporting. What is endometriosis? It is defined as presence of endometrial glandular tissue and stroma outside the uterine cavity, which occurs due to chronic inflammatory response or fibromuscular hyperplasia affecting the pelvic peritoneum, pelvic walls, and the organs. It usually affects women of reproductive age group and is associated with significant pathological effects. The estimated prevalence is approximately 10% in reproductive age females. Nearly 90% of infertile women with chronic pelvic pain also suffer from endometriosis. Coming to the various theories of origin of endometriosis, the first and foremost is the metastatic theory. In this, the endometrial fluid through retrograde menstruation gets deposited in the ovary or the peritoneum, causing chronic inflammatory response, or it can also spread through venous and lymphatic drainages. Coming to metaplastic theory, it is the differentiation of Mullerian duct remnants in the rectovaginal septum into endometriotic tissue. And coming to induction theory, wherever the endometrial tissue gets implanted, it induces special chemical substances which cause the undifferentiated mesenchyme to form the endometriotic tissue. The clinical manifestations are complex and depend on the location and extent, and there is a poor correlation between the symptoms and severity of lesion. The most frequent manifestations are dysmenorrhea, dyspareunia, and infertility. Other symptoms depend on where it gets involved. The three most clinical forms of endometriosis with increasing severity are superficial peritoneal endometriosis, which is not well recognized in imaging, and laparoscopy is the gold standard for evaluation of superficial peritoneal endometriosis. Ovarian endometriomas Ovary is the most common site for endometriomas. They are nothing but the endometriotic tissue which forms cysts with repetitive hemorrhagic content. And coming to deep pelvic endometriosis, it is the more severe form. It is defined as the endometriotic implants infiltrating the peritoneum of more than 5 mm beneath the peritoneal surface. Previously, histological confirmation with laparoscopy. Okay, can you hear me? Previously, histological confirmation with laparoscopy was regarded as diagnostic gold standard. However, DPE may be underdiagnosed during laparoscopy due to adhesions and deep lesions. False negative procedures may significantly delay the start of appropriate management and potentially lead to significant complications. At this moment, laparoscopy is recommended in patients with negative imaging results and poor empirical treatment response. A reliable diagnosis can be made based on symptoms, clinical findings, and strongly supported by imaging techniques like TVS or MRI. MRI is a well-recognized technique in diagnosing endometriosis with highest accuracy for DPE. The sequences which we use are T1 and T2 weighted sequences. Diffusion and contrast are used wherever necessary. T2 weighted sequence without fat suppression is the best technique for detecting pelvic endometriosis, and T1 with and without fat SAT are used for detecting endometriotic cysts and differentiating them from teratomas which contain fat. Thin oblique T2 weighted sequences are used for assessment of uterosacral and parametrial endometriosis. Coming to patient preparation, 3 to 6 hours of fasting with moderately distended urinary bladder will suffice. We need to use buscopan to decrease the peristalsis of the intestines, and for detection of deep peritoneal endometriosis, vaginal or rectal gel opacification is necessary to identify the rectovaginal disease, and abdominal strapping is necessary to reduce the motion-related image blur. IV and diffusion sequences are used wherever they are necessary, like contrast-enhanced T1 is used to differentiate endometriosis from suspected ovarian malignancy, and diffusion has high potential value to detect abdominal wall and sacral nerve root abnormalities in endometriosis. For better evaluation of DPE, the anatomy of female pelvis can be approached by using a classification based on pelvic compartments like the anterior, middle, and posterior compartments. This is the diagrammatic representation of sagittal MR T2 weighted sequence showing the anterior compartment between the pubic symphysis and the anterior surface of the uterus. It contains the pre-vesical fat, the urinary bladder, and the ureters. The middle compartment contains entirely of the uterus, both the fallopian tubes and the ovaries, along with the cervix and vagina. The posterior surface of the uterus and the rectum and the rectosigmoid form the posterior compartment. The rectouterine and rectovaginal pouches also come under the posterior compartment. Coming to ovarian endometriomas, they are usually seen as a T1 hyperintense cyst with T2 shading effect. That means they become black in T2 weighted sequence. If we find a T2 dark spot sign in the periphery, it means a chronic blood clot, and it is more specific for endometriomas. Restricted diffusion is variable in ovarian endometriomas. This is a T1 fat-SAT sequence showing ovarian endometrioma to be very much bright, which is showing T2 shading effect. And this lesion is also showing a dark spot sign at the periphery. And this case is also showing diffusion restriction within the ovarian endometrioma. This is another sagittal T2 weighted sequence showing enlarged uterus with a large fibroid, and behind the enlarged uterus, we find an ovarian cyst with layered appearance of T2 hypointensity, and it is a case of ovarian endometrioma. Coming to superficial peritoneal endometriosis, they are seen as small plaques or nodules, and they are usually missed and difficult to detect in MRI. Laparoscopy is a gold standard. Coming to deep pelvic pelvic endometriosis, DPE usually is more frequent in the posterior pelvic compartment. They appear as solid masses, plaques, or nodules which are T2 hypointense with intermediate signal on T1, and multiple millimetric foci of T1 hyperintensity within these lesions is giving a hemorrhagic powder burn appearance is specific for endometriosis. Adhesions are an indirect sign for deep pelvic endometriosis. Mushroom cap sign is solid invasive endometriosis of rectosigmoid colon on T2 weighted sequence, dilated fallopian tubes with hematosalpinx is endometriosis involving the middle compartment. And coming to anterior compartment involvement, bladder is the typical location with nodules at vesicouterine pouch. Either they present as localized or diffuse wall thickening. Other sites of involvement are abdominal wall endometriosis, like post C-section scar site, and inguinal and umbilical regions. Adenomyosis is presence of endometriosis within the myometrium, and along the nerve roots, as I have told earlier, along the sacral nerve roots, diffusion sequence will be more helpful. And along with it, if we see any muscle atrophy, it is an indirect sign of nerve root involvement of endometriosis. It also involves gastrointestinal tract like appendix and all. And if it is involving the thoracic cavity, it usually presents as nodules which present with catamenial pneumothorax or hemothorax. Coming to complications, there can be rupture of an ovarian endometrioma, or it can get infected. Coming to the places which it involves, like if it involves the urinary tract or bowel, they can present with obstruction. Malignant transformation in endometrioma is approximately 1%, and development of enhancing neural nodules is a more specific finding. Other signs include increase in the lesion size and lack of T2 shading. This is a case of bilateral ovarian endometrioma seen as T1 hyperintensis with T2 shading effect. Here, there is also a T2 hypointense solid mass affecting the rectouterine pouch with pull of the rectum, giving it a pear-shaped appearance. This is a T1 fat sat showing T1 hyperintensis at the rectouterine pouch. This is a case of deep pelvic endometriosis involving the rectouterine pouch. This is another case showing mushroom cap sign of rectosigmoid, where we find a solid T2 hypointense mass involving the rectosigmoid, which is infiltrating the posterior fornix of the vagina. And here we also find asymmetric wall thickening involving the urinary bladder, which is T2 hypointense. It is a case of endometriosis involving the bladder wall. This is the rectus. This is the most common site for involvement of endometriosis, where the uterosacral ligaments attach. It is known as torus utrinus. Here, this is a sagittal T2 image showing a hypointense nodule involving the torus utrinus. This is retrocervical endometriosis involving the posterior vaginal fornix. Here, this is another case showing the left uterosacral ligament, which is showing significant diffuse T2 hypointense thickening. This is another case of bilateral ovarian endometriomas with associated hematosalpinx. Coming to the involvement of bladder, here we see a large T2 hypointense mass involving the posterior wall of the urinary bladder along with the anterior myometrium. Here, small endometriotic deposit is seen in the posterior to the uterus, infiltrating the uterus. And it is another case showing a similar implant in the rectouterine pouch. Here, this is a case of abdominal wall endometriosis at the site of C-section, where there is a T2 hypointense nodule, which is T1 hyperintense, and showing mild enhancement in post-contrast examination. This is a T1 weighted sequence with contrast. Here we find a T1 hyperintense nodule involving the rectus abdominis, it is showing mild enhancement. It is a case of endometriosis involving rectus abdominis. This is a typical Gordon sign where there is a nodule with irregular margins and radiating fibrotic strands involving the rectus abdominis. This is a case of endometriosis which has turned to be an endometrioid cancer. Here we find a mass with a nodule at the periphery. This is the post-op scan, and in follow-up there was recurrence of the cancer, which is seen as an enhancing nodule at the same location. Coming to adenomyosis, it is the presence of ectopic endometrium within the myometrium, and MRI is the gold standard. It can be either diffuse or focal, and the most established MR finding is thickening of the junctional zone exceeding more than 12 mm. We find high intensity myometrial foci on T2 and T1 within the thickened junctional zone. This is a case of a globoid uterus showing thickened junctional zone diffusely in the anterior and posterior wall that is more than 12 mm with multiple tiny cystic foci scattered within the junctional zone. This is a case of focal adenomyosis involving the anterior wall. This is an atypical subserosal adenomyoma, which is showing T2 hypointense contents, which are T1 hyperintense, which on laparoscopy was found to be chocolate colored fluid. This is accessory and cavitated uterine mass involving the left lateral wall. Here we are seeing T2 shading effect with a layered appearance within the cavity, which is T1 hyperintense. On laparoscopy, we are able to find a bulge in its contour, which when opened revealed a chocolate colored fluid. This is another atypical case of adenomyosis. Here, there is thickened junctional zone of the posterior wall with the polypoidal mass projecting into the endometrial cavity. And here there is a T2 hypointense intramural fibroid. On post-contrast examination, this polypoidal lesion is enhancing to the same extent as adenomyosis. So it is a polypoidal adenomyoma projecting into the endometrial cavity. We see that the fibroid is enhancing lesser than the adenomyosis. This is an enlarged uterus, another case showing multiple fibroids with a typical polypoidal lesion projecting through the external os into the vagina. We find T1 hyperintense dots within with heterogeneous enhancement. It is a case of a typical polypoidal adenomyoma. This is another case. This is the non-gravid state of the same patient and the gravid state, showing thickened junctional zone of the left lateral wall with multiple scattered T2 cystic foci, which in pregnancy is seen along the left lateral wall of the uterus as increased in size along with a small fibroid posteriorly. This is a case of deep pelvic endometriosis involving the posterior serosa of the uterus and the posterior wall of the uterus. There is retraction of the adjacent rectum. This is a laparoscopic image showing the same with retraction of the rectum. Coming to pitfalls of MRI, non-pigmented lesions will not be hyperintense on T1 and thus harder to detect. Small foci are also very difficult to detect, and adhesions cannot be directly identified. We have to rely on ancillary findings like distortion of normal anatomy to imply their existence. And differential diagnosis, in the main one is the dermoid cyst, and it can be solved by using a T1 fat sat sequence. If it gets suppressed, if the bright signal gets suppressed, it means the cyst contains fat and it is a dermoid cyst. And hemorrhagic ovarian cysts need to be detected separately from endometriomas. Hemorrhagic ovarian cysts usually present with acute symptoms, and they usually resolve with time. And mucinous lesions, they are similar in appearance to endometriomas and show increased signal on T1, but usually less intense to fat and blood. Coming to staging of endometriosis, will be the American Society of Reproductive Medicine has given this staging, and it is from minimal to severe. Minimal includes a small number of superficial implants and mild adhesions. If it is more and slightly deeper implants, it is mild disease. Coming to moderate, small chocolate cysts on one or both ovaries with many deep implants and more severe adhesions. And severe form is large chocolate cysts on one or both ovaries with many deep implants, severe adhesions, and rectum may adhere to the posterior surface of the uterus. Last but not the least, I want to give a small gist on the structured reporting of these lesions, because it may improve the patient counseling, treatment planning, including the organization of multidisciplinary teams and selection of appropriate medical and surgical therapeutic strategy. In my report, I'll be giving the description of the lesions, whether they are placed in anterior, middle, and posterior compartments, and their site of involvement, and their number, and their dimensions. And in the anterior compartments for the ureters, if they're involved, I'll be giving about the distance from the uretero-vesical junction. For rectosigmoid lesions, we have to give distance from the anal verge, the deepest layer of involvement, and the circumference of involvement. With this, I'll be concluding my thing. Thank you.
Yeah, thank you, Dr. Srujana, for wonderful cases. Like a lot of examples you have shown, like which we don't like. Very
Yes.
very important for us to diagnose these things, which are very difficult to diagnose. Also, some areas really very difficult, even on MRI also. To pick up these lesions, but having an idea and having a approach really matters, like the compartmental approach and the distances from uretero-vesical junctions and what to see exactly, because otherwise radiologists usually they don't know, they think that endometriosis is a very localized condition. We don't try to suspect in unusual areas, but you have really shown multiple examples. Great. Thank you. Madam, any comments?
Yes, Dr. Lakshmi, I thoroughly enjoyed. Very good images. You have good collection.
Thank you, ma'am.
Madam, yeah, a few questions, like how early can imaging pick up endometriosis compared to clinical symptoms or laparoscopy? Any your experience, like how often?
See, this is a very peculiar disease where the symptoms and the disease of the severity are not proportionate. The disease may be very extensive. A patient may have bilateral big endometriotic cyst, but surprisingly, she will be asymptomatic. She will come for some other symptom. When we send for routine ultrasound, we will notice she has 6, 7, 8 centimeter bilateral endometriomas. She is asymptomatic. Sometimes we get exactly opposite case where clinically, except vague tenderness, there is nothing we are able to elicit any physical finding, and CA 125 may be marginally elevated, but her suffering of dysmenorrhea, dyspareunia, or dysphagia is very severe. So this one particular disease, symptoms, disease severity and imaging are not matching. And there are no correlating much studies also. There are various studies, innumerable studies are there, which are trying to analyze what is the etiology, what are the characteristic features, but nothing is matching. So it is not easy to detect very early sign without any symptoms. The first thing patient comes to us with symptoms. Then we have to have a high degree of suspicion because this has become a pandemic disease nowadays because people are getting late marriages, late planning of pregnancy, and whenever they come with dysmenorrhea, and most of the gynecologists will have high degree of suspicion, and we send it for relevant investigations. Also, we like to do CA 125, though it is not very characteristic of only endometriosis. It can be elevated in many other conditions, but it also helps in assessing whether this particular patient has disease suggestive of endometriosis. So it is a overall holistic approach we should have to suspect and treat this disease.
One more question, madam. What are the most common diagnostic pitfalls in imaging-based identification of endometriosis? Like we in ultrasound or MRI, we give few lesions, but during your surgery or laparoscopy, you find multiple lesions. That means there are a lot of pitfalls in imaging also. Like how?
So that is very true. As I told you, the symptoms, the imagiology, and the visualization at the laparoscopy may not be matching in every case. With the advent of 3D, 4D, and detailed MRI description, many diseases are matching, but not always. For example, superficial endometriosis. The irony of it, the active endometriotic lesions are not even darkly pigmented. They're active lesions, they're light pink or even pale colored. So you have to put saline on those suspicious lesions and look at them at a higher magnification to see whether it is a suggestive of endometriosis. People think laparoscopy doesn't give tactile sensation, but we developed haptic sensation. We touch the lesion with our instrument and we can feel there is a nodularity. Because nowadays we are going to get this haptic sensation, modern cars, everybody will understand what I am talking. You can...
Games, madam, games also.
That, yeah.
In video games also we get that sensation.
So you can assess what is the lesion you are watching. So don't be under the impression that gunpowder appearance or ink appearance lesions will be there. They are in fact burnt out lesions. They are not very virulent. These pink or pale lesions are most active lesions, and when you are doing laparoscopy, you specifically target them and burn those lesions, whatever energy source you are using, so that the patient will get the proper treatment. And one more area where we may miss is the rectovaginal nodules. Unless we have like a mapping of lesion before you just do laparoscopy, you may miss deep rectovaginal nodules. So laparoscopic surgery and imagiology are become complementary to each other.
So not all the lesions can be picked up on MRI or ultrasound also.
Exactly. Not all lesions 100% will be picked up. And second, you should visualize the entire upper abdomen and the pelvis. Endometriosis is not the disease of only pelvis. We have seen endometriosis of diaphragm, endometriosis of liver, very commonly endometriosis of appendix, omentum, all peritoneal surface. So it should be a routine dictum. When you put the scope, first see the entire abdominal cavity, including pelvic cavity, before you proceed with the proper surgery. The rarest rare case, laparoscopy beyond also, we have seen endometriosis of the eye, endometriosis of the lungs. These cannot be detected by only laparoscopy. So you should have lateral thinking and you should also have high degree of suspicion. The ophthalmic case, she was having only vicarious menstruation and bloody tears, and she was having severe pain.
Oh.
And after putting her on the medical management, her symptoms have subsided. So it is not only limited to its pelvis, it is manifesting in many. One of the theories, what she mentioned, lymphatic theory, will justify these lesions, but it is a disease which is going to be at a higher incidence in future.
True, madam. Yeah. So that means catamenial hemoptysis are I think that is there on this. Yeah. So epistaxis also, I think. Yes. Madam, when you take medical or surgical decisions in diagnosis of endometriosis, like whether you just follow with the medical treatment or when do you want to do surgery, is there any?
Depends on the patient age, whether she's paras, nulliparous, sometimes she can be very young adolescent girl also. So you should be as conservative as possible. The first line of treatment is always medical management only.
Right.
But if suppose there are huge endometriomas, 8 centimeters, no medical management will help her. So the choice of the management depends on the age of the patient, symptoms of the patient, her main complaint, whether fertility seeking or only pain relief. Then comes the burden of the disease and what is the extent of the lesion. Suppose the patient may be having severe dyspareunia and dyschezia, then you have to treat that particular symptom. But one thing is nowadays we have various medical options also. 2 decades ago, we had very few options, oral contraceptive pills or GnRH NLX. But now new molecules have come. So we have more option to treat the patient conservatively. And same thing in surgical methods also, targeted treatments, focal solutions with the advanced energy system and 3D laparoscopy with the crystal clear visualization of the lesions, all has added to the precision of the surgery and better results.
Okay. Thank you, madam. Thank you so much for all your inputs. So, that's Srujana, Dr. Madam, Fahmida, Banu, madam. So, the final our take is like imaging is very crucial for early and non-invasive diagnosis of endometriosis, and it is very valuable in suspected deep infiltrating endometriosis. That's what I think we came to conclusion.
To the moderator, because we know moderator is very knowledgeable. Can you add few things for the sake of my postgraduates? Elastography role in endometriosis.
Yes, madam. Yeah, elastography is nowadays useful for many conditions, madam, especially in cervical cancers also we are using, even thyroid nodules we use, breast masses we use elastography, of course liver fibrosis we use. So definitely there is a role of elastography in any conditions where there is a thickened structure like fibrotic, hard structures. We basically want to separate some soft structures from hard structures. So definitely it has a value even in endometriosis.
Thank you, sir.
Yeah. So TV. So according to the imaging wise, TVS is first and MRI is definitely comes next, but it is very superior for mapping the deep infiltrating endometriosis, and pre-surgical planning. MRI is definitely recommended, and cleared structured reports of MRI are essential for the gynecologist to plan their treatments and laparoscopic surgeries. And shared language between two specialties are very important, like both should talk in a similar words and terms, otherwise very difficult to understand. And yeah, definitely it is helpful for fertility preservation, surgical planning, and recurrence monitoring is also very important role for MRI and transvaginal ultrasound. So
on our radiologist by asking questions. What is the ureter involvement? What is the rectal segment? It is a clinically great for endometriosis. Patiently, they discuss with us, especially your Vijaya Diagnostic Center. So that has helped us in planning and treating our patients.
Thank you so much, ma'am.
Thank you.
Yeah, thank you. With this, I think we conclude this session. Thank you, madam. Thank you for joining us today as chief guest with your valuable time.
Thank you for sharing the academic platform. Thank you, sir. Thank you, Lakshmi.
Thank you, ma'am, for coming.
Thank you, Srujana.